I'm going to start back in 2006. If you recall, that's when Time magazine was throwing out this crazy idea that this guy named Barack Obama could possibly be running for president. And I was practicing internal medicine at Oregon Health and Science University, doing internal medicine, and I was leading an NIH-funded project about violence and depression in women of color. And that project was a community-based participatory research project. I do community-based participatory research, CBPR for short. So in my work world, I was hearing a lot from my African American and my Latina partners about everything that's wrong with science. And they were right. There were a lot of things that we as scientists do that really marginalizes people even more. While that was going on, at home I had my hands full. I had, several young children, and if you'll notice, one of the little kids here, my son Andoni, always had a little penguin at the end of his hand. If you pretty much any picture, you can find a penguin, and that's because Andoni 2 years earlier had been diagnosed with autism, and my life at home really revolved around autism and penguins. At the time, autism was sort of just starting to get into everybody's mind. And it wasn't getting into our minds in a very positive way. I can say, as a parent, I was being barraged with everything I had to do to fix my child, or else I would have screwed up. And there was a lot going on there. As about 2 years into the diagnosis, as I was finally over the where am I going to schedule therapies, I was in a parent group, an online parent group, and in that online parent group, there would often be parents saying, oh, I've got this problem, and 10 other parents saying, oh, I've got this problem too. And there would always be this one response from this woman who would always say, well, I don't know anything about parenting, and I don't really know if this is exactly what your child is experiencing, but when I experience this, this is what happens, and what I have found to help is this. And I thought these were the most absolutely useful, interesting bits and pieces. I started collecting them, and I wanted to meet this woman, but I knew that I couldn't just tell a random autistic person from the internet, hey, let's go have coffee. So I noticed that she had a special interest in science, and being that I teach evidence-based medicine, I devised a nefarious plan to come up with an autism journal club. Because I figured she would bite, and she did. And not only did she come to the journal club, she offered to have it in her house. And in her house, we had lots of conversations. And what I learned, largely from listening to her and then meeting and reading the works of her friends, was there's this huge rift between what was in the literature and what was actually important to autistic people. And there was a real lack of inclusion in the whole process, like what we were studying, at the time it was me, it was they, what was being studied, how it was being studied really didn't include autistic perspectives at all. Sometimes that actually resulted in real threats to study validity, in that things were actually done in a way that didn't make sense. And the dehumanizing, stigmatizing language was absolutely the norm. As I started listening to Dora and her friends, I realized that there were huge similarities between what I'd been hearing at work with my African American and my Latino partners and what I was hearing in my personal life by getting to know autistic adults. There was also this huge rift between what I was hearing as a parent from other parents and from clinicians and what I was hearing from my new acquaintance with autistic adults. So Dora introduced me to the neurodiversity paradigm, and I'm not going to go over it here since that's what we've been talking all day, but I'll say that the things that have ended up influencing my research have been thinking of autism as a form of diversity. And really we've talked already about the difference between thinking of it as an illness, where I as an internal medicine doctor was like, oh, my child has this illness that needs to be treated, versus really thinking of it as an identity, which I as a CBPR researcher, this is what I do. I partner with marginalized communities to figure out how to make their lives better. Also, we've touched upon the social model of disability, and really that's ended up changing very much kind of how we think of research in terms of focusing on inclusion, accommodations, and supports, and really also focusing on the environment and taking it out from that purely micro level of the individual and thinking about how the environment influences outcomes. And then an appreciation for both strengths and challenges. I'm very much into strength-based models, and I think there's sometimes a misinterpretation of strength-based models, that it's all about just sugar-coating things and pretending it's all good, and that's not whatsoever what we mean by strength-based models. We're meaning just really truly appreciating both strengths and challenges, and the way that strengths and challenges can actually be the same thing at times. It can be really interrelated. And then we have to remember that the neurodiversity movement comes out of the larger disability rights movement. And there's the longstanding motto of nothing about us without us, which fit very well with my approach as a participatory action researcher, which really truly believes that the way you do good research is to include the people, not as the subjects you're researching, but truly as your colleagues, your partners, your team members. So I'm going to talk today about kind of how a neurodiversity paradigm may affect research team composition and approach, our choice and framing of study topics and research questions, how it affects just nitty-gritty our research materials and interventions, and then how we then think about using a neurodiversity paradigm when we're disseminating findings in the literature. So, participatory approaches, some of you may be very familiar with them, some of you less so. These have come from, traditionally they've been used to address racial and ethnic disparities to improve outcomes. They're a response to traditional research, and the whole idea is that representatives from the communities or populations being studied become a part of the research team. We're not just asking them, what do you think we should study? We're not just, including them in studies. They become part of the team. There are many, many different participatory approaches. I get kind of geeky about it. I could talk to you for the next hour about it, but today we'll just focus on it in a broad way. It's an approach and can be used with any method. Sometimes people think of it as just with like social sciences or whatever, but this is an approach that could be used for genetics for all I care. It's really an approach to research. And it's intended to strengthen the quality and, most importantly, the impact of research. So Dora and I met in our journal club with some other parents and some other autistic adults really only a handful of times before we figured, wait a second, why are we sitting here critiquing the literature? Why don't we change it? So we formed the Academic Autism Spectrum Partnership in Research and Education, or ASPIRE. And ASPIRE, since 2006, has grown quite a bit. We're now an international group that includes autistic adults, academics, family members, disability services providers, healthcare providers. Many wear multiple hats. I'm not meaning those as separate categories. And so we work together to improve to improve lives of autistic individuals. When you're working with a lot of stakeholders, there's always this question comes up with, well, but autistic adults may have different perspectives than parents and may have different perspectives than clinicians. And I've struggled with that, especially knowing, again, as a parent myself, and I've personally come to terms with it thinking about the LGBTQ analogy. If I were doing work to try to improve the lives of the queer community, I would center the voices of the queer community, and then of course we need to include stakeholders, because this doesn't happen in a vacuum. And of course we need to include parents and clinicians and disability services providers, but we include those that are willing to center the voices of autistic adults. I said we use CBPR. The point is that we have autistic adults serving as equal partners throughout all phases of our research process. And as I said, some wear different hats. Dora, when I first met her, was my lead community partner. In the 13 years since we've met, she has gone back to school, gotten a PhD, become an assistant professor in our institute, and is leading her own NIH-funded studies. So we definitely believe in capacitation, but but we also really believe in including autistic adults who may have no interest, resources, abilities to be in academia. So we really do include folks who are in and outside of academics. So this is our model of CBPR. And actually, one of Dora's great talents is I'll just info dump and she'll make cool figures. So back when we were first starting, I kind of info dumped about everything I knew and thought of CBPR, and she helped me create, well, together we created this figure. The idea of CBPR is that community and academics work together as equal partners. The community overall keeps the research respectful, accessible, and socially relevant. Academics overall keep the research scientifically sound and academically relevant. That doesn't mean we do exactly the same things. It means we work together at each phase. So when we're coming up with a question, what to study, we want to, the community helps us make sure that this is something that meets their priorities at the same time that I've got to figure out this actually advances science and meets the funders' priorities. Same thing while we're doing the work, same thing when we're distributing the work. It doesn't mean that I as an academic fade into the background. It doesn't mean that I as an academic control it. It means that we really learn from each other all the time, and that I respect the lived experiences of people, and they respect what I bring as an academic. And again, several of us switch hats and have many roles. So making that actually work is a lot harder than it sounds. And there's a lot of theory about CBPR, but when it comes down to it, it means actually making it happen. We actually just published our guidelines on inclusion in the journal Autism, and that has way more than I can cover on a slide. But for me, things that really stand out are, one, being really, really clear about roles and responsibilities. Being very thoughtful about power sharing. We use a structured shared decision-making process, because if we don't, I will accidentally step on people's toes. But when we use a shared decision-making process, we can be sure that, in fact, we have come to consensus. We've done a lot to have meeting formats that advantage our autistic partners. When we first started 13 years ago, I was very uncomfortable with online text communication, and we decided we had to have our meetings in instant messenger, type chat. That was the best experience for me, empathizing with what it's like to be autistic, was to be in a mode that is not my preferred mode of communication. It was hard. Now, 13 years into it, it's second nature and it's fine. But it really helped for us to have meetings in a mode that worked best for my community partners. We do all sorts of things to make sure materials are in advance. There's clear agendas. We do strong facilitation. And then part of making joint decisions is making sure that people really can make those decisions. So it means using accessible language, really explaining things in ways that people can resonate when they're outside of academia, whether or not they're even on the spectrum, that we're not speaking as scientists. And we put a lot of effort into making sure that people can really be at the position where they can make true decisions. Other things, we use a structured email format. We do a lot of individual accommodations. And then we know that we don't get it all right, so there's just this constant evaluation and little check-ins and little changes, and over the years we've changed things so many times I've lost track, but it matters. Ultimately, it comes to earning and maintaining trust, and that doesn't come easily. That doesn't come because of a diagram of how we work together. That comes from years of really, being very authentic and trying to do the work. So again, how does it influence research in general? First is the choice of study topics or research questions. As I said, I think neurodiversity can affect any field, any discipline. This does not have to be a particular research question, but it does come down to a little bit, are you trying to prevent or cure autism, or are you trying to improve the lives of people on the spectrum? And I think that distinction is really fundamental. If you're really trying to rid the world of autistic people, it's going to be hard to do this. But if you are thinking of how to improve people's lives, there's a host of possibilities. And these are just, I'm not even going to read through them because there's so many and there's so many more, but there is research in any type of discipline, in any type of field, that I think could be easily done using a neurodiversity paradigm. So I'll tell you about our own projects. So in the last 13 years, Aspire's done a large series of our projects have been around healthcare. Again, as a health services researcher, that's probably not surprising. But we've done a survey about disbarriers and barriers to care. We've done some qualitative studies, and then we used a series of studies to develop our Aspire Healthcare Toolkit, which I'll show you in a little bit. And now we've got a series of studies trying to integrate it into the health system. Dora has been leading a number of studies around skilled employment. She's just finishing up an NIH-funded study, a qualitative study, and she just got a Career Development Award last week. I'm really excited so she can continue this work in thinking about how to make workplace culture, how to change workplace culture to be more autism friendly. We also have smaller projects going on. Dora's leading a project on autistic burnout, and another one of our colleagues is leading a small project about post-secondary education. I don't want you to think that it's just Aspire, so I'm going to mention some of our other partnerships. This is a project we did. This was a CDC-funded study about the relationship between violence, health, and disability in people with developmental disabilities. We again used a CBPR approach. That one was a broader developmental disability focused project. And ultimately, we created a way to anonymously collect data directly from people with developmental disabilities, because you can't even do violence research if you can't do it anonymously and directly. And then we also had a project about pregnancy that was in autistic, sorry for the language, this was a number of years ago, so our project was titled about women, I should say women and non-binary individuals, but we did a qualitative study about pregnancy, both in people with intellectual disabilities and autistic people. So how does this actually affect the materials and the interventions? Now I'm going to get into nitty-gritty, but part of science is actually getting the nitty-gritty right. So part of what happens is how do we actually make it so that we can be collecting data directly from autistic individuals. You know, a lot of autism research is done in little children, and if you're talking about 2-year-olds, you're going to ask their parents whether they're autistic or not. But our research is focused on adults, and we tend to not ask people. I mean, there are studies out there that ask, you know, young adults' parents, autistic young adults' parents about their, like, you know, sexuality and their relationships, and you wouldn't do that in another population. So some of this is figuring out how can we maximize as much as possible getting people to be in research themselves. So one is the consent process. You know, we appropriately have a lot of protections of people with potential decisional impairment. At the same time, we also fine line between having appropriate protections and actually being patronizing and keeping people from being in research. So we do a lot to try to really maximize autonomy while still protecting people. Our community partners have been absolutely key in making that happen. We completely change our consent forms, and all those things that say you're not allowed to change it on the consent form, that's not true, because really the point is to have informed consent. So I'll give you an example here of a portion of one of our consent forms. You'll notice it uses a question and answer format. It uses lots of pictures. It uses very clear language. And by using, you know, very accessible consent materials, we've been able to get informed consent from people who otherwise may have been excluded. And then how we ask questions. I'm a mixed methods researcher. I do both qualitative and survey research. And for surveys, I found that in general, you can't just use surveys without thinking about it. So what we've done is we work very closely with our community councils, be it Aspire or any of the other projects that I showed to you, to try to make these surveys accessible. I'll tell you, when I've gone over instruments to measure potential constructs with my community partners, by and large, they find them to be completely inaccessible and or offensive. And these are instruments that I see now being used in autism studies, but we don't actually know that they're getting valid results because they're just taking an instrument that's been developed for a general population and just using it with an autistic population. A lot of my partners have said they felt they would experience significant confusion, frustration, anxiety, or anger if trying to answer these questions, and they've stated that faced with such measures, they would offer unreliable answers, they could leave things blank, or they'd stop participating in the study. So why? We've basically, as we've adapted like close to 20 instruments. In that process, we have found that there's a lot of common concerns, often difficult vocabulary, confusing terms, figures of speech, imprecise language, complex sentence structure, abstract concepts, and then sometimes really ableist language or concepts. And then what do? So again, this is not like neurodiversity, but it matters. It matters in these like little bits and pieces. So we work with our partners to adapt these, trying to keep the construct as close to as possible to the initial one. We often will put in prefaces, we'll simplify sentence structure, we'll clarify pronouns, we'll substitute difficult vocabulary. If we can't, we add a hot link where you can click on it and get an example, or you can get a definition. We'll add graphics. And ultimately, and sometimes we've had to add additional items because the construct's a little bit different in autism. These are some examples. I won't go through all of them, but I'll point to the bottom one. This was an example that came out of our project that was a cross-disability study. And we were using instruments that had response options that the option was none of the time, a little of the time, some of the time, most of the time, all of the time. I think anybody in this room can tell why this is a little bit of a problem. What's the difference between a little bit of the time and some of the time? So our autistic community partners were suggesting, well, you should say 10 to 25% of the time, or 50 to 72% of the time. And our partners with intellectual disabilities were like, wait, no, this math and percentages, and you can't do that. So this is where working together was really helpful, because ultimately the group came up with these cylinders where somebody could look at it and get a sense of how much the cylinder was filled without bringing in math, but adding some precision to this very imprecise language. We also work hard to make sure that our data collection modes are accessible. This is an example of our audio computer-assisted survey instrument system, where you'll see we worked with our community partners to make the chapter's really clear. There's options for different font sizes. There's a read out loud option. There's an ASL option to make it accessible. And doing so has really helped us actually collect data. In this case, it was really important that we could anonymously collect data about violence, and we were able to do that with people feeling that it was very easy to use and easy to understand. It also affects our interventions. This is the Aspire Healthcare Toolkit. We co-created this with our community partners. The point is to try to help people get better primary care services. You'll notice there's a portion for patients and a portion for providers. Every word of this has been co-created with our partners to make sure that it's accessible and useful. The centerpiece of the tool is our Autism Healthcare Accommodations tool, where basically a patient or a supporter fills in a questionnaire, a multiple choice questionnaire, and then the computer turns it into a personalized accommodation report for the provider. Because as a provider, and I can tell you as a primary care provider, it's very hard to say, okay, this is what you do for autistic patients. This gives a very personalized list of accommodations. This is an example of the patient information, very, very detailed. Again, meeting what our partners felt was important. There's a bunch of different forms and worksheets that people can use to help them navigate the health system. And again, so far we've had some pretty nice results in terms of people finding it helpful and it reducing the number of barriers to healthcare and improving patient-provider communication. So all of this then goes to, how do we then talk about this? I can tell you for ourselves, it really matters what words we use, how we disseminate this information. We collaborate very closely with our community partners to make sure we're presenting findings in a way that reduces stigma or harm. Our partners are co-authors. Some of our partners especially for the partnering project, there are folks who may not even be able to read the article. What we do is we offer lay translation tables. We make sure that people have truly understood what's in there to be able to meet authorship criteria. We also try to use strength-based language as we've kind of already talked about. There's a lot of things that I think really matter in how we talk about autism. Things like, again, the preference for identity first language, but also really thinking about, are we talking about autism as an illness or a disease, or are we talking about it as a disability or a condition? Which brings us to our new journal, which I'm so excited about. So a little while ago, Marianne Liebert of Marianne Liebert Incorporated contacted me asking me if I would be editor-in-chief of this new journal that they were thinking of putting together. And the first day when she called me, I said, do you know who you're asking? Like, if you ask me, this isn't going to be a normal journal. And she said, great. And I have to say, I've been very pleased to have publishers who've embraced our idea of this is not going to be a normal journal, and that we're going to do our best to be a very, very scientifically rigorous and impactful peer-reviewed journal, but to do it in a way that really appreciates the autistic community and autistic adults. So, we're focusing on, again, whatever are the most pressing issues affecting autistic adults, anywhere from emerging adulthood to later life. Our editorial board worked very hard to come up with a language policy, and in fact, that's basically our language policy. So we have a formal policy for the journal around using strength-based language. So Dora is our associate editor, because I can't do anything without Dora, and we have a total of 10 autistic adults on our editorial board. Plenty of our other board members also have their own connections to autism outside of their professional world. And then we're playing with a number of things. One is that all of our papers, in addition to having the traditional 2 scientific reviewers review them, we also have an autistic review. Now, sometimes the scientist may have been autistic, but in most cases, that's not the case. So the autistic review is really focusing on, is this important? Is this respectful? Is this useful? And then we also have, there's the normal abstracts, but we also have fairly substantial accessible lay summaries. We've worked on the format, even just you'll see in our first few issues, they've changed format because we've tried to get them more and more accessible. Now we're using a question and answer format for those. And then in addition to lots of papers, we've had quite a few scientific papers that have been authored by autistic individuals. We also have an insight section in each issue that really focuses on personal perspectives of autistic adults. So a few take-home points. The neurodiversity paradigm can absolutely shape and affect how we do research. And again, I've gotten into some of the minutia, but the bigger idea is, what's our point here? Are we trying to, rid the world of this terrible disease, or are we actually trying to make the world a better place for autistic individuals? It's not just an idea. It takes a lot of thoughtful hard work, and each of these things take, and I've been doing this now for a long time. I'm still constantly having to rethink things because there's a new idea comes up or a new issue comes up. Ultimately, I think this has the great potential to strengthen the quality, relevance, and impact of research. I don't think it's one particular type of research. My stuff happens to be services, but it certainly doesn't have to be about services. And really, I'm looking for folks to help move the field forward. It's incredible how much things have changed in the 15 years since my son was diagnosed. I'm thrilled with the changes, but we have so much more we can do.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.